40-year-old male with alleged history of RTA, car versus lorry. He was the car driver. He has contusion in his pelvis. BP was 70/40. Heart rate was 130 by 130 per minute. A single large bore IV cannula is in place. And injection tranexamic acid 1 gram IV was given in the field. The ambulance will arrive in another 10 minutes. I believe all of you are ATLS trained.
Yeah, we are all
ATLS trained. Okay, so initially we will make the preparations. So initially we will wear the PPAs and we will make the.
Want to know our names or level?
Yes, I would like to know the levels actually.
Nurse. All are nurses.
All are nurses. Okay, so.
For you want now?
I want one more person actually.
Doctor or nurse?
Doctor is fine.
Okay. Doctor.
Anyone is ATLS qualified?
ATLS. All are ATLS.
ATLS. Okay. So we will make all the arrangements. So initially for the C-spine restriction, you arrange the C-collar and for the airway, you arrange the suction, the OPA.
All airway equipments arranged.
All airway equipments arranged. Coming to the breathing, you should arrange the NRBM, the bag and mask, portable chest X-ray, the ICD tray and the pericardiosynthesis tray should be everything arranged. Coming to the circulation, you arrange 2 large bore IV cannulas and tranexamic acid, IV fluids, portable echo machine, Thomas pin, pelvic binder. And also you should inform the trauma team and the blood bank that we are able to receive this patient who is in hypotension. Then inform. Then coming to the disability.
Blood products, what all?
O negative is required.
How many units you want?
At present, I need massive. If I am anticipating a massive transfusion protocol, also activated. Coming to the disability, I want a torch and a knee hammer. And coming to the exposure, we can switch off the AC such that hypothermia can be prevented.
Okay, done.
Okay.
The patient has arrived.
The patient has
arrived.
So,
and the paramedics.
So, kindly.
This is a 40-year-old male, Mr. Kiran. He had a RTA, car versus lorry, and he was a car driver, and he had contusions in his pelvis. Initially, his heart rate was 130 per minute. BP was 170 by 40. We could succeed in placing 1 large bore IV cannula, and 1 gram Tranexa has been given. Right now the patient is here. Doctor, it's too paining. Doctor, it's paining.
So we will follow the XA. Initially we will give pain management. Since IV cannula is there, kindly give injection PCM 1 gram IV stat, and we will proceed ahead with the XABCD.
1 gram IV stat given.
And we will go ahead with XABCD. Is there any exsanguinating hemorrhages at present?
No, there is no exsanguinating.
No exsanguinating hemorrhages. So Shreya, can you apply the manual inline stabilization for this patient?
Manual inline stabilization done.
Stabilization has been done. So coming to the airway, before applying the cervical collar, I would like to know, is there any tracheal shift, any elevated JVP, any subcutaneous emphysema?
Airway is patent. Is it patent?
Airway, it's in secretions.
Airway is patent.
Airway is patent.
Able to talk.
Able to talk. So, is there any tracheal shift, any elevated JVP, any subcutaneous emphysema, any stem deformity?
Anything? No, nothing is there. In the neck.
Nothing is there.
In the neck.
In the neck. No lacerations also there.
No lacerations.
So, you can at present apply the C-collar, Philadelphia C-collar can be applied.
Just demonstrate Philadelphia C-collar. Demonstrate.
Manual inline stabilization should be applied, and this is the anterior part, the chin.
Apply.
This is the one that should be supporting just below the mandible. This should be the anterior, and manual inline stabilization. Along with that, you have to place this posterior. This is the posterior part.
Okay, done. C-collar applied.
So now we come to the breathing. So
anything more to be done in the airway?
Airway is patent as of now.
And you want to apply any oxygen? Give some oxygen.
That is in the breathing part. We will start NRBM and 50 liters O2 has to be connected. So kindly.
It's in the AA itself. NRBM is high flow O2. Done. Okay, it's given. Okay, now moving on to B.
Then I would like to know the saturation, the respiratory rate.
Saturation is 100%, respiratory rate is 20.
20. So now I would like to know on inspection, I will look at the any lacerations, any abrasions, any decreased air movements, any asymmetry, anything is there on the chest?
No, probably this. No, I think more you want to look for specific.
Any penetrating wounds, anything is there?
Penetrating.
No penetrating wounds. No sucking chest wounds is there. So then we come to the
Neck, anything.
previously I have asked this tracheal shift elevated GV, that was not there. That's why I applied the speak collar in this patient. So then we come to the oscillation part. I would like to know how's the air entry process.
Bilaterally equal.
Is there any muffled heart sounds?
There is no muffled
No
heart.
muffled heart sounds. So I would like to go with percussion. Is there any dull note, any bilateral resonant note? So we have taken care of the breathing part. So then we come to the circulation. Circulation.
You want to do?
At present, I no need, sir. I am addressing the life-threatening injuries only at present. Then we come to the circulation. Coming to the circulation, kindly place.
Cannula is already there.
Kindly place one more large bore IV cannulas and give IV fluid 1 liter before I collect samples, including the pre-op serology.
Done. Everything is done.
Then you administer 1 liter of.
Cannula placed.
1 liter of crystalloid you can administer the bolus, and also already 1 gram tranexamic acid given. Ringer lactate can be given. Balanced crystalloids. Ringer lactate.
Anything more you want? Plain. This thing or?
It should not be to prevent hypothermia. Then
Yeah, it's already on flow.
also you can give injection tranexamic acid 1 more gram at present. You can give up to 2 gram IV stat as per the
One more stat or
over 10 minutes we can give.
first dose is already given over 10 minutes.
We can give up to 2 gram IV stat as per the newer guidelines.
Second dose?
Again 1 gram. Either you can give 1 gram.
Over how many?
You can give 10 to 20 minutes. You can give either 2 gram.
Back to back 10 minutes, 10 minutes.
Yes, you can give up to 30 minutes. Yes, 30 minutes. 2 gram over 30 minutes you can give. 10 minutes it was given previously before arrival actually.
Then one more there. Given.
Tranexamic acid has been given. Then we now look at the BP, the pulse rate.
BP 70, 30. Pulse rate is 130.
The capillary refilling time and is all the peripheral pulses equally palpable?
Peripheral pulses are palpable but feeble.
Feeble. So patient is having hypotension. Is there?
Yes, right. Lactate is 10 and
10.
SB is 7.
That is most likely secondary to hemorrhagic shock. Is there any blood on the court?
No.
Floor? No blood on the floor.
Yes.
So kindly please arrange the POCUS machine, and also you can inform the in the gastrosurgery team that we are receiving a patient with hemorrhagic shock. So kindly connect to the trauma team actually. By that time I will do I will look at EFAS for this patient at present.
I think before that you in the chest.
Is there any pneumothorax?
No.
Is it cardiac tamponade?
No.
Right upper quadrant any free fluid?
But you want the inspection, or you straight away want to do ultrasound or?
I am doing ultrasounds straight away
Straight away.
for hypotension.
Right type of, no.
EFAS I am doing.
No free fluid, right?
Left side any free fluid?
No free fluid.
No free fluid. Subxiphoid process any free fluid?
No free fluid.
Suprapubic region any free fluid?
This is the.
So there is a free fluid in the suprapubic region. If fast is positive. So anyway, we can activate the massive transfusion protocol, and also we can apply pelvic binder for this patient.
Negative blood has arrived.
Alright, so you can continue negative blood. By the time we can apply the pelvic binder. So parallelly, by the time you arrange pelvic binder, is there any long bone fractures?
No
long bone fractures. So one thing you have to remember in applying pelvic binder is that you need to log roll the patient. At least 4 people are needed. And at this present, since it's a trauma case, I have to look for a rectal examination to look for any high riding prostate, any blood at the tip of the meatus, so we can't catheterize the patient at present, and also we need to look for retroperitoneal injuries by the time we are doing applying pelvic binder. So kindly log roll the patient and apply pelvic binder at the level of the greater trochanter.
It's done. Log roll posteriorly also no bleed.
No bleed. So again, I will come to reassessment of the patient. How is the airway now? Airway is patent. Breathing
Air entry
bilaterally equal. Saturation is maintained. Again, circulation. What is the BP even after
BP is
massive
improving,
transfusion?
BP is improving.
BP is improving.
90.
Okay. Then I will come to disability. How is the GCS of the patient?
GCS is full.
GCS is full for the patient. Then how is the any lateralizing signs?
No lateralizing.
No lateralizing signs. Pupil equally reactive. So coming to the exposure, you can cover the patient at present with warm blanket. Make sure there are no penetrating injuries.
Mostly you want to look for
Any other penetrating injuries. We have a check for
only the pelvic contusion is there.
only pelvic contusion.
We have already applied the pelvic
pelvic binder. Okay. Exposure, we have prevented hypothermia also in this patient. So is the trauma team, the surgeon available?
They're still coming. Again?
Again, I will reassess the patient. Airway is
Now
patent.
the trauma team is here.
The trauma team is here. So I would like to spoke with the person.
Yes,
I am Dr. Abin. I am the team leader. I have received a patient with alleged history of RTA, car versus lorry. And on our initial primary trauma assessment, we came to know that the patient is having a suspecting, the EFAS was positive in the suprapubic region, suspecting pelvic fracture also. So we have applied pelvic binder and we have started massive trauma protocol. The BP is slightly picking up. We need, with the patient is unstable, to be taken for CT. So the patient should be shifted to the OR for exploration.
Yeah, like suppose if the BP has improved, what investigation will you order? After your blood transfusion, BP has improved, is relatively stable. So, what investigation you will consider, or
Again, I will do a CBC hematocrit, any dilution.
radiological investigation? If said unstable, you take for OT. If the patient is stable, next what will you do?
If the patient is stable, we can take the patient for CT if the patient is vitally stable.
What investigation?
CT abdomen.
Okay. What are you going to look for there?
The vessel that has caused extravasation.
Okay. If there is any active arterial or bleeding, if there is that, you can always consider an angio embolization, which is a recent modality. Now they are considering angioembolization almost for every kind of injuries, whether it is liver, spleen, wherever the patient is relatively stable, you can always go for an angio embolization. Okay. Then I think you've done almost everything very well, but we should always specify warm fluids. Okay, that is why I had prompted whether you want a warm fluids or not. Okay, because what is the lethal triad in trauma?
Acidosis, hypothermia, coagulopathy.
No, so you want to prevent all those things. So the major thing is you have to restrict the fluids, whatever giving, prevent hypothermia, and start early blood products to prevent any dilutional coagulopathy. Okay, and in hemorrhage control, it's always we were looking for some of the causes for the source for the bleeding. In abdomen also we should do a clinical examination. First thing is the clinical examination. Only then comes the focus or your EFAST. Okay, EFAST is always an adjunct or this thing only. Okay, so you should do your clinical examination. Look for the signs of any source of bleeding and manage it. Only then later we can add your EFAST. Not just directly go to the EFAST. Okay. Yeah,